Hi, this is Dr. Joshua Cooper, and the subject of this video is temporary epicardial pacing wires that are often present after cardiac surgery. We're going to review the best practices in terms of management of these wires and review a couple ways that they can be utilized that you may not have heard about before. Let's start with this X-ray image that was taken in a patient who's post-cardiac surgery. The notable findings here with regard to pacing include this tangle of little wires that's overlying the abdomen, which includes a little knot in two of the wires here and a knot in two other wires over here. And these little wires end in these connector pieces that themselves are attached to larger wires that run off of the image. Of course, when you go to the bedside, it's clear what these structures represent. This small tangle of wires are these two white and two orange wires. A lot of them, the tangled part is underneath dressings that are attached to the abdomen. These, of course, are the connectors that we saw, and the larger wires are these blue and brown wires that, if you follow them, are connected to a bedside pacemaker box that is used to control the pacing. The blue wire is connected into the atrial port, the brown wire is connected into the ventricular port, and this temporary pacemaker box can do a lot of things with regard to making sure that the patient is not bradycardic, and some other features as well that we will review. Let's first review what these temporary epicardial pacing wires look like so you understand what happens when they enter the skin and head toward the heart, and also how they're placed in the first place. Here is a typical epicardial temporary wire in its packaging. It looks a lot like suture, where you see this blue insulated portion, you see a bare metal portion heading toward a curved needle, and you see the other end heading toward a long straight needle. Here is a similar type of temporary pacing wire unpackaged, and again you can see the blue insulating material along most of its length, and this bare metal component heading toward a curved needle. This end is the end that the surgeon uses to thread this bare wire electrode through the epicardial surface of myocardium. As I will show you in subsequent images, this curved needle is threaded through myocardium, and you pull this metal component through the myocardium. And in fact, this is the interface. This is the metal component that touches myocardium and is responsible for pacing. This long straight end is used to bring this wire out through the skin surface. That same straight needle can be broken off, leaving this portion, which has a blunt end once it's broken, and this in fact acts as the electrode that is connected to the connectors that then themselves are plugged into the temporary pacemaker box. There are different types of temporary fixation mechanisms that the cardiac end of the wire may have, and there are different brands and different models within brands. A standard one is this straight end here, which the surgeon may put a little curl on the end of it to make sure that this does not dislodge prematurely, but there are other types of temporary fixations, little soft tines, a zigzag preformed shape, a little hook or a loop where the end is sewn under a suture on the myocardium, and this can be pulled through, and the surgeons will manage these post-operatively, and if they don't come easily, there's obviously concern about damaging the myocardium, so these wires may end up being cut and abandoned in place if they don't pull out freely in the post-operative period. This is a really nice image showing a surgeon holding that curved end of the needle with the bare wire component, ready to throw it, in this case, through atrial tissue, and usually two of these are thrown through atrial tissue and two of them through ventricular tissue, and then all four wires are brought out through the skin surface. Here's an image that very nicely shows that latter component where the straight needles were bunched together and threaded through the soft tissues, and they come out the skin of the upper abdomen. There's often a knot that is then tied to prevent inadvertent migration of the wires being pulled back into the body. And here are those ends after the long straight component, the sharp component of the needles were broken off. These ends are connected to, this is a different kind of connector than I showed in a previous image, but again, this is what allows these temporary wires to connect to the external pacing box at the bedside. Here's another image that shows two white wires coming out through the skin and two orange wires coming out through the skin, each one with a little knot. Again, sometimes there's a dressing that covers this component. Here in this particular image, I'll highlight that in our hospital, we typically use white wires as a convention to indicate atrial wires and orange wires to indicate ventricular wires. It's important to know and have a standard convention because otherwise, if these were the same color, it could be difficult to know what the other ends were connected to inside the body. Just in terms of location, you can see a sternotomy dressing here. So these are coming out just underneath the rib cage in the upper part of the abdomen. And our convention also is typically to use the blue connector wires for the atrial leads and a brown connector wire for the ventricular leads. But again, every hospital and ICU will have its own convention. Here's a lateral chest X-ray, again highlighting the root of these temporary wires. There's two of them that are attached to atrial tissue and two of them that are attached to ventricular tissue. And you can see these all joining together as the surgeon exited them out underneath the rib cage and out the upper part of the abdomen. It's interesting here to just compare the size of the wires to the sternotomy wires here, and this patient actually had a permanent pacemaker implanted, and you can see with some motion artifact there the permanent pacemaker wire caliber compared to these small temporary wires. Of course, the insulation of these temporary wires doesn't show up, so you're seeing these really thin lines reflecting just the metal internal component of these temporary epicardial wires. Here's a nice cartoon that I like to use to think about epicardial pacing systems, especially when it comes to troubleshooting. You can see here two atrial wires connected to the atrial epicardium and two wires connected to the ventricular epicardium. And when they're connected to the external pacer box, of course, one of these wires will be used as a cathode, the negative pole, and the other used as an anode, and the same thing in the ventricle. Here's just another image of one type of connector, and I'll show in the next slide how these are connected to the epicardial wires. But here you can see the ends that plug into the external pacer box and these screw type connectors that connect to the little pins after the sharp needles are broken off in the operating room. Here's a close-up view of one of the ventricular wires attached to the cathode port here. When this screw is loosened, righty-tighty, lefty-loosey, when this is loosened, this little opening becomes a little wider and this pin can be slipped in, making metal contact to the metal graspers, and then this is tightened around so the pin can't slide out, making sure metal is contacting metal, and the same thing for the anode. So this external pacer box will function just like a standard permanent pacemaker that has two leads, if in fact there are two sets of epicardial wires. And here we can see in this top image atrial pacing going on. And remember, of course, that on telemetry, the telemetry system has something called pacemaker mode that tells the telemetry system, please draw big lines where you think you see small pacer spikes. That's the reason that the color on the pacer spikes is different from the color of the rest of the EKG. It's because these black lines are in fact not recordings, but they are superimposed drawings that the telemetry system will show to help augment the tiny little green pacing spikes. In fact, you can kind of see one of them here on this particular channel. And again, the telemetry system is just trying to help us by augmenting that and making it bigger to make sure that we can see that pacing is occurring. Here in this bottom image, there's both atrial and ventricular pacing. You can see two black spikes drawn in by telemetry. Here in this bottom tracing, it's not picking it up, so there's a little tiny atrial pacing spike and a ventricular pacing spike. And you might see those, but again, telemetry is usually activated for pacing mode so that the augmentation, the drawings are very prominent and there's no question when pacing is occurring. So the main reason that these wires are put on is because in many cardiac surgeries, there may be a reason for temporary or longer term dysfunction of the sinus node or AV conduction or both. In heart transplant patients, the sinus node may be temporarily or permanently injured, and particularly in valve surgeries, tricuspid valve surgery, aortic valve surgery, the AV conduction system can be temporarily or injured in the longer term, requiring temporary or permanent pacing. So here's a patient who has sinus node dysfunction after cardiac surgery, and you can see there's junctional rhythm occurring in the low 40s, and you can see retrograde P waves occurring after each junctional beat. And here we have the initiation of temporary epicardial pacing in the atrium and in the ventricles that speeds up the heart rate. A lot of the times we're asked to pace the patient faster in order to improve blood pressure. And embarrassingly, for a long time, I thought that this was a silly notion, thinking that if the patient has low blood pressure, then a faster heart rate isn't necessarily going to fix the problem that led to the low blood pressure, because it probably has a different etiology, because most people with a heart rate, in the 40s are not hypotensive. And in fact, the evidence that I would point to support my claim that faster pacing doesn't help blood pressure would be images such as this, where you can see that we have bradycardia on the left and faster pacing on the right, and the blood pressure did not change whatsoever. However, what I didn't recognize is that there can indeed be a blood pressure effect. And in this patient, if I only were to be patient and wait a little bit longer, I would have noticed that as this patient were paced faster for a longer period of time, the blood pressure did in fact improve with no other changes made to the pressors or other medications that were being used on this patient. This blood pressure improvement was solely due to the faster pacing. And just like priming a pump, this blood pressure effect may not appear immediately, but it may have a slight delay. And in fact, in this patient, after 1 minute of pacing, we saw a jump in the systolic blood pressure from the high 60s to the 1 teens. You had almost a 50-point increase after 1 minute of pacing, proving me wrong, of course, in this particular patient. Now, I'm not saying you're going to see blood pressure improvement in every patient where you pace them faster, but I wanted to correct those who, like myself, thought that pacing in a faster rate can't help blood pressure. Here's evidence to the contrary. And in fact, after 2 minutes of pacing in this very same patient, the blood pressure, proving me further wrong, rose from the high 60s up to the 140s. The patient is now hypertensive simply due to faster pacing. Because the surgical team after cardiac surgery often does want the patient paced at 80 or 90 or 100, sometimes for very good reason, we'll often look at telemetry and see that the patient is constantly paced, which raises the daily question of what is the patient's underlying rhythm. Do they have sinus bradycardia underneath pacing, or a junctional escape rhythm, or are they completely pacemaker dependent with asystole underneath? And there are different techniques for answering this question, and you may get slightly different answers depending on what technique you use to see what the underlying rhythm is. And the reason for that is the sinus node or a junctional escape rhythm, it can be suppressed during pacing. And if you suddenly stop pacing, it may take a number of seconds for that sinus node to wake up and start functioning again, or that junctional escape rhythm to wake up and start working again. So you may get false impression that the patient is completely pacemaker dependent with asystole if you suddenly disconnect the pacer box and pull out, or suddenly turn it off and look at the underlying rhythm that way. You may see a long pause, and if you don't wait to see that in fact a junctional rhythm kicked back in, you may have the false impression that this person is completely pacemaker dependent. On the other hand, if you turn the pacing down more gradually, like this, looking at the rate knob and turning it down from 100 to 90 to 80 to 70, etc., you're more gradually going to give opportunity for a junctional escape rhythm to kick in. You won't have that same long pause, and you'll appreciate that the patient, in fact, can have a rhythm on their own, and they're not 100% dependent on pacing. this is not just an academic question, it may have practical relevance, because if the temporary pacing wire threshold is going up and the patient has asystole underneath, especially if you're approaching a weekend, you need to come up with a different method of pacing, because if pacing stops capturing, then you may be in a medical emergency because the patient may have asystole and you may no longer be able to accelerate the rate via pacing. So knowing whether the patient is completely pacemaker dependent or not is a very important question that should be asked every single day in postoperative patients. Here's an example of the daily threshold testing that can be performed on the ventricular lead in particular, but the atrial lead can be done as well. And what's happening here, and the question that we're asking, is what is the minimum amount of energy that is needed to capture the myocardium? And what will be done in this case is the device will be unlocked and the patient's output in the ventricular lead, for example, will be turned slowly down, 10 milliamps, 9, 8, 7, and you're going to watch on the bedside telemetry when you start to see pacer spikes with intermittent ventricular capture and then complete loss of ventricular capture. And then you've answered your question, you turn it back up so that pacing can be resumed. And the number that is associated with capture, that's the lowest number, let's say 5 milliamps, is called the pacing threshold. You'll see day after day in the postoperative setting that that number will go up, because that metal electrode, that strand that is threaded through the myocardium, will get inflamed. There's local reaction in the myocardium to that metal, and that local inflammation will create a barrier to the transmission of electricity, and that pacing threshold will go up. In standard pacemaker leads, in permanent pacemakers, the metal that is interacting with the myocardium, that's touching it, is a very different type of metal, and there is steroid that is impregnated in that distal electrode to reduce inflammation. And that's how we achieve a very low chronic stable pacing threshold in permanent pacemaker leads, but that is not present in these temporary wires, and so they have a limited lifespan in terms of their effectiveness in capturing myocardium. And so it's important to know if this number is going up, and now their pacing threshold on postoperative day 4 is now 12 and then 14. There's a maximum amount of energy that this temporary pacemaker box can deliver, and if you're approaching that, then you're soon going to run out of room and no longer be able to capture the myocardium. And if the patient is still reliant on pacing, then one needs to anticipate that timing and figure out a different solution for temporary or permanent pacing. Here's an interesting phenomenon that you sometimes may see during threshold testing with temporary epicardial wires. What are we seeing here? We have one pacing QRS morphology. As we're lowering the energy, we see a different morphology and then loss of capture. And at first you might say, well, maybe there's a PVC or that's some anomaly that I don't understand. But as we quickly turn back up the pacing output, we see that second morphology appear again. And what I'm not showing is when the morphology is further increased, it went back to the first morphology. So what's going on here that we have two different pace morphologies from the very same pair of wires attached to the ventricular myocardium? What's actually occurring is, remember that there are two wires and one is an anode and one is a cathode, and you can actually get capture from both or only from one. It is a pacing principle that the cathode, the negative electrode, typically has a lower pacing threshold than an anode. The negative pole captures myocardium more easily than the positive anode does. And as you're coming down at higher output, you may be capturing both, and then as you lose capture from one, you may have a different morphology reflective of pacing from one site rather than two. Going back to this cartoon diagram, it wouldn't make sense to see two morphologies if the two electrodes were right next to each other, because really, if you pace from one or the other, the cathode or the anode, it should generate a very similar QRS morphology. But often the surgeons will place the second wire at a distance, and they're not right next to each other. So when you capture from both, you get a fusion of the QRS complex from the morphology at this location and the morphology at this location. And then when you lose capture from the anode as you're coming down on the pacing output, then you're going to see the QRS morphology that reflects capture from only the cathode site. Here's another troubleshooting point to make. This patient, who is getting paced epicardially after cardiac surgery, had pauses on the telemetry and occasional alarms showing loss of capture, bradycardia, and pauses. And if you go on the telemetry trend, which otherwise when capturing had a very flat heart rate trend, of course, because the pacing box is delivering a very precise heart rate that'll give you an absolutely horizontal straight line of heart rate. If you click on these naders, these low points where the heart rate is slower, and then review the telemetry, you're going to see these pauses. Or of course, looking at the alarms on the telemetry themselves will reveal these pauses. And the question is, why is this happening? So as we zoom in here on the telemetry strips themselves, we can see that indeed there are cardiac pauses that are occurring. And not only are there absent QRS complexes here, there are absent pacer spikes. This is not a case of elevated pacing threshold and loss of capture. This is an example of no pacing occurring whatsoever. And it's happening over and over and over and over again. So we can't explain this away by thinking that maybe somebody at the bedside was checking an underlying rhythm. That would have occurred only once or maybe twice, but not repeatedly over and over again. So there's something else going on. What's happening here is the pacemaker box is thinking that there's cardiac activity occurring in the ventricles and the pacing is being inhibited. This is something known as oversensing. The pacemaker box is seeing electrical signals that are not coming from the heart, but of course the pacemaker box can't distinguish one type of electrical signal from another. Electrical signals could also be generated by muscle contractions in the patient's abdomen or chest, but through other electrical devices that are near or attached to the patient, or even movement of the wires themselves that can generate electrical signals, electrical interference that can be detected by the pacemaker box, and it may think that heart activity is occurring and therefore it may not need to pace, again called oversensing. This occurs in any pacing mode where the pacemaker box actually cares to look at what the heart is doing and respond accordingly. That would be the VVI mode or the DDD mode. That middle letter, V or D, tells us that the pacemaker unit is looking at the ventricle, V, or dual, the ventricle and the atrium, and in both cases it will inhibit, it will stop pacing if it sees electrical signals in the ventricular channel. But clearly here, the signals that it is seeing are not coming from the heart, and therefore pacing is inappropriately being withheld. So what do we do about this? There are a couple ways that this can be quickly managed. And the easiest way actually is to find the emergency button here, which actually turns the pacing mode to asynchronous. It says it in really small type here, but async means that it will change the pacing mode to an asynchronous mode that's VOO or DOO. That can also be done manually. If you go into the menu here in the bottom part of this type of pacemaker box, you can actually find, in this case, the dial mode, switching the DDD or VVI to DOO. That would do the same thing as switching to async. And another way this can be troubleshot is that you can change the sensitivity to electrical signals in the ventricular lead. This is one of those scenarios where the number seems backward. Here we have a ventricular sensitivity of 2.0 millivolts. If you make this number higher, that makes the ventricular lead less sensitive. What this number means is this is the height of signals that the device is able to see. So if you raise this number and say, 5 millivolts instead of 2 millivolts, what that means is it's only going to be able to see things that are greater than that number. So that's why a larger number means lower sensitivity. So you can, if you see these pauses occurring, you can make this number higher and higher until you stop seeing these pauses in the activity, and then it will continue to sense the QRS complexes, which usually are a larger amplitude signal than the electrical noise that may be causing inhibition of pacing. You can also, in simpler types of pacer boxes, see a dial that will have ventricular sensitivity, and you'll see numbers, and you can turn that dial to higher and higher numbers, which makes the sensitivity lower and lower to prevent inappropriate inhibition of pacing. And just as in that dial, the same electronically here, when you get to the highest number, the next setting right after that is something called async. Asynchronous. That means it's sort of an infinity number. Don't look at anything in that ventricular lead, just pace no matter what and ignore any signals that you're seeing. And that would be, of course, the best way to prevent inhibition of pacing. Although a caveat, as we'll review in a short bit, sometimes you don't want the pacemaker to just pace no matter what. You want it to inhibit if there are real ventricular events happening, because you don't want the pacemaker to pace on top of T waves, which occasionally can actually lead to proarrhythmia, as we will review. So the async setting has a hazard that you may have inappropriate pacing output at the wrong time. So it's best often to find a sensitivity number where it is appropriately inhibiting when QRSs are occurring, but there isn't inhibition of pacing during periods of silence due to other smaller electrical noise in the room or in the patient's body. Here's another example of a problem that can involve some troubleshooting. This patient has intact sinus activity. You can see the P waves occurring without pacing, and has intact AV conduction. You can see relatively narrow native QRSs occurring, and yet there's pacing that is occurring just after the onset of each of these QRS complexes. It's unnecessary pacing that's occurring on top of QRS complexes. Is this dangerous? No. Pacing on top of a QRS is not going to cause any problem whatsoever, like pacing on a T wave can, as we'll review. But it's unnecessary pacing, and it's kind of using up the battery in this temporary pacing box, and it's just simply unnecessary. So how do we troubleshoot this? What is the problem going on here that somehow the pacemaker doesn't know that native conduction is occurring? Well, just like a permanent pacemaker, there's a setting called the AV delay. That is the amount of time that you tell the pacemaker to wait after it sees a P wave to decide whether conduction is occurring and whether it needs to pace in the ventricle. And that number can be increased or decreased. And in this case, the AV delay is set at too short a number. We're not giving enough time for the pacemaker to see if native conduction is occurring. And in fact, it's just about a tie. Just at the time that conduction is occurring, the pacemaker's little AV delay clock elapsed, and it said that it needs to pace. Here is what happens the moment we extend the AV delay from the default 200 milliseconds to a longer number, 270 milliseconds. We can see in the first half of this strip, pacing is occurring on top of QRSs, and then when we extend that, that stopped happening. So here, the pacemaker box is waiting an additional 70 milliseconds, which was long enough for it to see, oh yeah, there is native conduction occurring. I guess I don't need to pace, and that phenomenon stops occurring. This is a setting that you'll find in the menu here below. Again, it's called the AV interval or the AV delay. And when you toggle to that setting and you turn up the knob, you can change that number to a larger number, which again will give a little bit more time between the P wave and the ventricular pacing. If conduction is occurring, the pacing will then appropriately inhibit, assuming, of course, that you're in a mode, the DDD mode, where it will in fact inhibit when it sees electrical activity coming from the ventricles. Here is another problem to troubleshoot, and it looks a little bit confusing because this is a very busy telemetry strip, but let's see what's happening. And the first thing I want to call your attention to is what's happening with pacing here. If you look carefully, you're going to see that there's two pacer spikes, atrial pacing and ventricular pacing, and it's occurring. And in fact, it's occurring all the way through this strip at an absolutely regular interval, and it's completely oblivious to native heartbeats that are occurring in the atrium or the ventricle. This is dual chamber pacing that's occurring with no sensing happening. And we reviewed before that you can easily tell a pacemaker to do this if you program it to a very insensitive mode, a very high sensitivity number, which means it's very insensitive, or if the mode is programmed to asynchronous, DOO, or the asynchronous button is pushed. And unfortunately, there are consequences to asynchronous pacing without sensing native activity, and there are two of them in this case. One is that sometimes the atrial pacer spike is occurring in a vulnerable time during atrial diastole, and it is causing repeated episodes of atrial fibrillation. We are causing iatrogenic AFib in this post-op patient with atrial pacing at inappropriate times, and that's happening over and over again. Now, these episodes at the moment are self-terminating, so the AFib is stopping, but we're causing AFib, and it just could have easily continued, and now you're creating a post-operative AFib situation that was not occurring on its own. The other issue that can be of concern is we're seeing pacing occurring on T waves. And again, as we'll review shortly, that can cause ventricular fibrillation if you're pacing in a vulnerable time in the ventricles on top of T waves. Thankfully, in this patient that didn't occur, but it probably was a near miss that we're having pacing occurring all the time on T waves as shown by these arrows on the bottom of this telemetry strip. Here's just a close-up seeing the ventricular pacing spike occurring on the terminal portion of this T wave, and it was occurring over and over again. And it turns out this was happening for many hours. And when you look back at telemetry, there were episodes of tachycardia, rapid atrial fibrillation, sometimes picked up as, quote, VTAC, just simply because of the fast rate, but others were appropriately called sort of SVT or just tachycardia. And the telemetry was showing for many, many hours in this patient, these episodes of proarrhythmia associated with asynchronous pacing. What occurred? Well, it turns out that somebody at the bedside had accidentally hit the asynchronous pacing button. And you can see, first of all, asynchronous pacing is occurring, and that's shown here at the bottom window of the bedside temporary pacemaker. But in addition, when the emergency button was hit, that's this, DOO, this emergency button, not only does it make the device pace in a DOO asynchronous mode, but it cranked up the outputs to max. This is a bad combination because it isn't simply that the pacing spike was occurring in a vulnerable period in the atrium or a vulnerable period in the ventricle, but if you crank up that output, you're more likely to cause atrial fibrillation or polymorphic ventricular arrhythmias when you're pacing on a T wave. So the combination of asynchronous pacing and high output pacing while there are native beats occurring can there's a formula that leads to proarrhythmia. So this was an accident. Somebody had accidentally at the bedside hit the DOO button, was not aware that that had occurred, and that resulted in this continuous DOO high output pacing. And then of course, the moment that this was restored back to DDD pacing with appropriate sensitivity, these proarrhythmia episodes stopped occurring because pacing was only occurring as needed and not on top of native beats. Here's another example where the sensitivity in this patient was set at a level that was too high a number, too insensitive. This was not asynchronous pacing. You can see there isn't pacing occurring throughout this time. It's appropriately sensing QRS complexes, but just barely so, because the pacemaker box missed the fact that there was a QRS complex here, and it paced right after, thinking there was no heartbeat. And unfortunately, that pacing spike in the ventricle occurred on a T wave, and it caused polymorphic VT to occur. And you can see this is real, not artifact, because you can see the arterial line tracing dropping off, because obviously no perfusion is occurring during polymorphic VT. Interestingly, the small signals generated during polymorphic VT were too small for the pacemaker to sense, just as the normal QRS was in this case. So you can see inappropriate ongoing pacing occurring during polymorphic VT. And this kept going until the clinical team rushed to the bedside, defibrillated the patient with a shock, and therefore restoring a normal rhythm and pacing when necessary. And of course, after these events occurred, the pacemaker box needed to be adjusted in terms of its sensitivity, so it stopped pacing at inappropriate moments. Here's another near miss example where polymorphic VT could have been reinitiated with pacing on this T wave here, but thankfully it didn't capture. It was maybe a little too early in the refractory period, so a QRS was not generated. Here's just a bird's eye view on the bottom, showing that this occurred actually multiple times. And here on the top, you can see more near misses where you had pacing on a T with a couple beats here and a couple beats here and a couple beats here. And in fact, you can see that in the bird's eye view on telemetry that this was happening multiple times. Here is where polymorphic VT occurred. And it kept going until defibrillation occurred. But afterward, actually, this happened again, and it self-terminated, and again. And then finally, the sensitivity was appropriately adjusted so that these pacing spikes on T waves stopped occurring. Again, this is more likely to be proarrhythmic at higher output pacing, but sometimes as the pacing threshold gets higher over time, then you need to crank up the output in order to capture when it's necessary for pacing to occur. So you have to be very careful with the sensitivity in these devices so the device is not too sensitive and doesn't pace when it should be, but it's not too insensitive, so it's pacing at times when it shouldn't. So again, bedside management of these devices is very important to avoid each of these complications. Here we have this ventricular sensitivity number. Again, just to remind you that if you were to see this pacing on T wave, we would do the opposite of what we did before when there was oversensing. Here we're having undersensing, and we want the ventricular lead to be more sensitive. So in this case, we would make this number smaller until we reliably saw the sensing light flash with each native QRS complex, reflecting accurate sensing of intrinsic cardiac activity. I'm going to switch gears here and talk about a completely different use of epicardial wires, one that you may never have thought of or heard of before. Here's a patient who had a heart transplant who has epicardial, atrial, and ventricular wires in place. And this patient went into a rapid SVT, and here's an EKG of that SVT. And of course, what we're looking for is P waves to figure out what is the mechanism. There are different SVT mechanisms. And as we look through here for P waves, we might say that maybe we see little P waves here in V1 before the QRSs, but hard to see them in the other precordial leads. And as we look here in the limb leads, lead 2 has this sort of undulation. Is this AFib? But that's regular, so probably not AFib. Is this artifact? We don't actually see that undulation in any of the other leads. So one use of, in particular, the atrial epicardial leads is that gives you an opportunity to look at electrical activity of atrial muscle without ventricular muscle as superimposed. And here's what I mean. If you, while doing a 12-lead EKG, take the V1 electrode, the wire that you normally would connect to the sticker on the chest in the V1 position, but instead you attach that wire to one of the atrial epicardial temporary wires, you're going to see an EKG that now looks like this. What we're seeing here is atrial activity superimposed only in that V1 lead on the EKG itself. And what we're seeing here is there are 2 atrial events for every 1 QRS. So we are in some rapid atrial tachycardia or atrial flutter, and it becomes crystal clear what the rhythm is by using the atrial temporary electrode attached to V1. Now, I don't recommend attaching that electrode to one of the limb leads because you're going to start seeing this atrial electrogram on all of the EKG electrodes because the limb leads are used in multiple leads, so you're going to start seeing this artifact everywhere. But the best convention, I think, to use is simply rely on V1 and attach that to the atrial electrode and then take the EKG and then indicate on it somehow that this was performed with the epicardial atrial wire attached to V1 so that somebody who didn't know that it was performed is not confused as to why you see this, what otherwise would look like artifact in V1. This is real atrial activity. We would call these little spikes electrograms from that atrial wire. Here is how you would perform that. The V1 EKG electrode, depending on the model of EKG machine that you have, is usually some type of clip that normally would hook up to a tab or an electrode on the patient's body. But instead here, you can take one of those wires. Again, remember in our system, we use the white wires by convention, or the atrial wires, you can take one of those and you can connect it. This is a different type of alligator clip. Sorry, I don't have a picture of hooking up the EKG electrode to it, but basically the same thing. And now you've established electrical continuity between this epicardial atrial wire and the EKG machine, and it'll give you this type of recording and make it crystal clear what's happening in the atrium. Here's another patient, post-cardiac surgery, who went into SVT. And there's a little bit of artifact here. And again, you're looking for P waves and say, oh, maybe it's there. Is there a second one in there? I don't know. And so it's just not always clear in the postoperative patient what's happening in the atrium. But here again, we took the atrial electrode, one of the two, it doesn't matter which one, and hooked it up to V1. And here we can see that there's one atrial electrogram before each QRS. So this is a 1-to-1 atrial tachycardia. And that tells you this is not atrial flutter. This has implications on whether this patient should be anticoagulated, for example. The previous patient was in atrial flutter, and you might then consider initiating anticoagulation. In this case, not necessary, because the atrial rate is exactly the same as the ventricular rate. So this is not a scenario where that's needed. And this, again, can help diagnostically. If this happened suddenly, this is likely an atrial tachycardia. If this kind of built up gradually, this could even be sinus tachycardia if the patient had a reason for sinus tach. But the important point here is that there's a 1-to-1 relationship between atrial activity and the QRS complexes. This is not a new thing. Here is a manuscript that was published a long time ago, in fact, back in 1978, where they talk about using temporary epicardial atrial wires to record atrial electrograms to establish the diagnosis of an arrhythmia or confirm the diagnosis of an arrhythmia. So don't think that I made this up. This goes way, way back. I'm not that clever. And there's a historic, as there are in many things in medicine that we sometimes forget and then reinvent or revisit a time later. So this is an age-old technique that you now have learned about and you can use in your practice as well. Let me show you yet another method of implementing these epicardial wires that may be novel and even more magical perhaps than sensing on the EKG. Here's that same heart transplant patient who went into this 2-to-1 atrial flutter rhythm, and this patient had had post-op bleeding complications, and so they couldn't easily anticoagulate because there were post-operative surgical concerns about recurrent bleeding. And this patient was also awake at this point, not intubated anymore. And their blood pressure was somewhat tenuous. And so sedating them and cardioverting them, of course, was an option to do it before this patient were in this atrial flutter for too long. But we came up with a different solution and yet another way to use epicardial wires. You can do rapid pacing from that temporary box, not just bradycardia-related pacing, but rapid pacing to pace terminate an atrial arrhythmia. Let's have a look at how that is done. Here is this patient in the atrial flutter, and here you can see that telemetry is capturing us pacing at a rapid rate through the external pacer box, which I'm going to show you has settings that allow for rapid atrial pacing. And here we have terminated the atrial arrhythmia, and now we're back to sinus rhythm or atrial pacing, depending on the rate that's, of course, programmed in the device. Here, I think it's at 110 beats per minute. So this atrial flutter was magically converted back to atrial pacing at 110 beats per minute through rapid atrial pacing and pace termination of this atrial arrhythmia without the need for sedation. This is essentially painless for the patient, and therefore you don't need sedation like you would for an electrical cardioversion. One important caveat before we move forward is that you need to be darn sure before you start pacing in the heart through the temporary box at this rapid clip that you are in fact pacing the atrium. You would not want to do this in the ventricle. Being unaware, you could easily put this patient into ventricular tachycardia or ventricular fibrillation if you did rapid burst pacing, in this case over 200 beats per minute, in fact maybe close to 300 beats per minute in this case. So you need to, and what I do as a convention before I start rapid pacing is I do test pacing to make sure that the white wires are the atrial and make sure there's no confusion. I will pace at a rate just slightly faster than the patient's heart rate. So in this case, for example, if the pulse rate is 154, I will, before I pace at this rapid rate, pace at 160 and just make sure I'm not capturing ventricular myocardium and creating faster QRS complexes. And only after I have done this test pacing just above the ventricular rate, okay, then I can go to rapid pacing and pace at 300 or whatever I need to do that's faster than the atrial arrhythmia that I'm trying to terminate. So here is the bird's eye view of this patient's telemetry, and you can see here at 4 p.m. or so, the patient went into this rapid arrhythmia. It came to clinical attention, and we were able to pace terminate it, within, 20 minutes or whatever it was. And so the question of anticoagulation was tabled and wasn't an important concern at this time because we could get the patient very easily and painlessly back to sinus rhythm and atrial pacing. And if you look at the bird's eye view on the telemetry, you can see that in this case it took 4 attempts. Now I would recommend that you consult with your friendly neighborhood electrophysiologist before doing this, before you start doing rapid pacing. There are some techniques associated with how fast do you pace, how long do you pace for, because basically the pacemaker box, which will allow for this, rapid atrial pacing, when you go to the correct menu item, you program the heart rate, which in this case we got up to, well, actually this is just a figure from the internet, but 320 beats per minute, but you can pace even up to 800 beats per minute. I don't think that would ever really capture at that rate, so you rarely would go this high, but if you're in atrial flutter, then you could very easily need to pace faster than 300 beats per minute in order to terminate that atrial flutter. So here there were 4 total burst pacing attempts. I tried a little bit faster than twice the ventricular rate, meaning a little bit faster than the atrial rate. Here I pushed the button and held it, didn't work. I, at the same rate, pushed the button and held it a little bit longer, didn't work. I did it a 3rd time, that was maybe a little bit faster, didn't work. I did it a 4th time, a little bit faster, and that's the one that finally worked. So you want to do just the minimum amount of pacing in terms of rate and duration that works. And if it doesn't work, you can always go a little bit longer, and you can always go a little bit faster. And sometimes you can provoke atrial fibrillation, and sometimes that corrects itself. If you have organized flutter convert to fib, sometimes that burns itself out and you go back to sinus rhythm. Or be aware that if you in fact accelerate the atrial rhythm, you may in fact need to cardiovert, but you needed to anyway, so you haven't potentially lost anything in doing so. So the point here is that this is a really nice technique in a patient where you're not able to easily cardiovert because they're awake and they have tenuous blood pressure, and you just don't want to sedate them in order to cardiovert, and you don't want to hurt them by cardioverting them without sedation, and you want to get them out of an arrhythmia promptly. These epicardial atrial wires can serve this purpose as well. Here's a more practical issue in terms of troubleshooting, and one of the most common things that you may see in the postoperative setting in a patient who has temporary epicardial wires. Here is a patient that we are having pauses in the heartbeat, in this case due to loss of capture. Before we reviewed oversensing and inhibition of pacing. Now we're dealing with the scenario of loss of capture, and the reason we know that is we can see pacer spikes, telemetry drawn in, pacer spikes, and absent QRS complexes. So this patient's pacing threshold has gone up and has now surpassed the setting that was programmed in the ventricular channel on the temporary pacemaker box. And that may be the maximum. You may already be at 20 or 25 milliamps and may lose capture. And that may be a problem because the patient may have bradycardia or even asystole. And if this wasn't anticipated and an alternative method of pacing wasn't arranged, then you may be in a little bit of trouble and figure out, well, how do I get this to capture again? There are methods that you can use to try to lower the pacing threshold by manipulating how these wires are hooked up. We talked earlier about the anode and the cathode. Here are our 2 orange ventricular epicardial temporary wires. One of them is hooked up into the cathode, the negative electrode, and the other is hooked up into the anode, hooked up to the pacer box. And often when there's inflammation, scarring around these wires at the level of the myocardium, it's not symmetric. It's not equivalent around the two. There may be one wire that's better than the other. So one option that you have is you can switch these two electrodes and use the one that was the anode as the cathode. Maybe that wire is the better of the two wires. Maybe there's less inflammation. You can potentially lower the pacing threshold. You have a 50-50 chance one wire is better than the other. And if you're already losing capture with the way it's set up, you can quickly, unscrew each of these and do a really quick change around and switch them out. Remember which is which, of course, and see, you might have a better pacing threshold. Maybe you're losing capture at 20 milliamps in one way, but you drop it down to 12 milliamps in the other way, and that gives you a little bit of extra time to come up with an alternative pacing option. Another thing that can be done is if you figure out which of the two ventricular wires is working better than the other by doing this switcheroo, then take the one that's better, meaning the one that works better plugged into the black cathode, and leave that plugged into the black cathode, and you can use something else as the anode. Maybe that other wire is really inflamed and just doesn't act as a good anode. You can actually use, especially in an emergency, you can use an atrial wire, one or the other, as the anode. You really doesn't need to be hooked into ventricular muscle. You can do what's called unipolar pacing. Have one electrode attached to ventricular muscle, and the other one anywhere else in the body, including using one of the atrial wires. And that can sometimes lower the pacing threshold. And again, I would use, when you swap these out, if you see which one has the higher pacing threshold, use the lower pacing threshold wire in the black, that orientation. Take the red one out, put an atrial one in, and see if the pacing threshold is better, is lower with that configuration. And the last option that you have, again, is to use the better ventricular wire in the cathode, but as an anode, you can actually use a skin electrode. Sometimes the surgeons will put a fifth temporary wire, suture it through the skin to act as an indifferent electrode, or just for unipolar pacing, just a skin electrode. Or you can put any needle into the skin, and instead of using these screw type connectors, you can, if your ICU should also have alligator type connectors, and then hook one, I'm showing the atrial, but I really should have shown ventricular, one hooked up to the ventricular wire that's better, and then the other one hooked up to a metal needle that's just stuck into the skin as an anode. It's another emergency way that you could potentially configure the system and lower the pacing threshold in an emergency where you're losing capture and you really need to come up with another solution. It may not work, but it is something that you can try and can sometimes temporize things until you come up with a better pacing alternative. And just to, again, review those different types of connectors, here are these screw type connectors that hook up to the pins that I showed. Here are a very similar set of wires with the same color scheme, and of course the same ends that plug into the temporary pacemaker box, but you can use alligator clips to hook up to the pins. This is maybe less secure and could potentially fall out as opposed to the screwed in version, but this would allow you to hook up a second one to a skin electrode, for example, if you needed a needle in an emergency like I just showed. And again, in both cases, the atrial and the ventricular ends, of course, will plug into the pacemaker box in their respective channels. So let me summarize what we've gone through here. Epicardial surgical wires, of course, are used to help with postoperative heart rate in patients with sinus node or AV conduction problems, and I've learned can help with blood pressure, often not immediate, but sometimes after a minute or two. Not always the case, but you can sometimes see a boost in blood pressure with faster pacing. You check the underlying rhythm, at least on a daily basis, by gradually turning down the rate to allow the sinus node or the junctional rhythm to recover and not just suddenly have a long pause because you suddenly called upon the escape rhythm to occur, and it may take a few seconds for it to wake up. But if you gradually decrease the rate, then it'll wake up and you'll see it more readily and more accurately reflect what the patient's underlying rhythm may be. Oversensing and undersensing problems can be solved by adjusting either the pacing mode or the sensitivity, in particular in the ventricular channel, making sure that it is seeing true QRS complexes and not pacing on T waves because it missed the QRS, but also not inhibiting pacing inappropriately when QRSs aren't occurring. And so you can tweak that sensitivity dial or number digitally while watching the telemetry and the little flashing light to make sure that it is in fact sensing the QRS native complexes. A rising pacing threshold can be troubleshot by swapping the wires, the anode and the cathode, or finding the better wire and using something else as an anode, either an atrial wire or a skin electrode. The atrial wire can be connected, one or the other can be connected to the EKG lead V1 to diagnose what the atrium is doing when there is a supraventricular arrhythmia. You can use rapid atrial pacing through the temporary pacemaker box to terminate an organized atrial arrhythmia, atrial tach or atrial flutter, being careful that you're not accidentally rapidly pacing the ventricle. And in most ICUs, or all, they should have protocols for management of these temporary pacing systems. The nurses are all in-serviced on this. They have protocols how to manage them. Many places have a policy where you tape another 9-volt or whatever batteries that the temporary box can tape it to the back of the unit, so that if suddenly the battery gives out, you don't have to go suddenly and search for extra batteries. It's right there. Always have fresh batteries literally taped to the device. You can quickly swap it out if needed, and other protocols to make sure that these patients are safely managed. I hope that this was helpful to you and that maybe taught you a few new things about management of temporary epicardial wires in the postoperative cardiac surgical setting.